Hey everyone, it's Dr. Chris Shaver, host of the GI Show, and we are here with you for the GI Show. And we're talking about irritable bowel syndrome, which is a really important topic that you need to know about. In fact, I've titled this Understanding Irritable Bowel Syndrome for the first time because number one, I kind of want to demystify it for you guys and just sort of help you understand it on a kind of a core level. And also I don't want to really assume what you do know about it. And so I want to dispel any myths or misunderstandings that may be taking you down the wrong path in understanding and dealing with maybe your diagnosis of irritable bowel syndrome. So anyway, welcome. We are filming here at the lovely BGA Studios. So I'm very excited to present to you my special guest, Dr. David Landy. Dr. Landy, would you join us, please?
Sure. Thank you very much.
Good to see you. So let's transition here at the GI Show with Dr. David Landy, my special guest, talking all things irritable bowel syndrome. And by the way, let me go ahead and mention this. Is please check out our website. We at bgapc.com. It is a valuable tool for you guys. You can reference physicians. You can look at our blog, which has a lot of information about IBS and all the other things GI. We post previous episodes of the GI Show. So bgapc.com would be a good resource for you guys. So check that out. So treatment, Dr. Landy, IBS. So we have really treatment really falls into two camps, the IBS diarrhea predominant and the IBS constipation predominant. We use some of the medicines interchangeably, right? But let's sort of get into IBS with constipation. Decreased stool frequency. Form is going to be more solid, hard, small, and obviously frequency is going to be significantly reduced. So treatment options. Kind of what's your sort of algorithm for treatment, starting with over the counter, and
Sure.
Take it from there.
Yeah, I'll usually start with fiber. You get fiber in your diet. Everybody gets some. In this country, not enough. And I always tell people I ask people to supplement their fiber with. I start with like Metamucil, like a powdered fiber to start with, because that way you can kind of measure it and you know what you're getting. And I'll tell people to do 3 to 6 grams, which is 1 or 2 tablespoons, and mix it with a lot of water. Drink lots of water. That tends to help the constipation. I kind of feel like it's it's kind of a bulking agent. It softens the stool, and so it kind of helps either the diarrhea or the constipation in my mind.
That's true. Sometimes at the expense of bloating, and sometimes we have to sort of dial it up and down based on bloating as a side effect. But I agree, it's a really good first place to start.
Sure, and that's why you start low, because 3 to 6 grams when you're trying to get maybe 20, 30 grams in your diet, it's not a lot. So I do tell people to go slow, titrate it up. Your body can adapt to it. Even with the bloating and the gas, too much fiber is going to cause more gas and bloating. Right. But sometimes adding a little bit can help.
And the great thing about fiber is that it's really, really safe.
Yeah, very, very safe.
Yeah.
So I would start with that as far as just non-prescription. And non-prescription, I would also use Miralax. If constipation is more predominant. I think Miralax is a great laxative. The polyethylene glycol type laxatives, very good because they're powder, and again you can titrate the exact amount. You start with 17 grams, which is like a capful of Miralax.
It has a lot less side effects to me than a lot of the other over-the-counter laxatives.
Absolutely.
And the one thing I found with it is sometimes I can overshoot the target a little bit. And some people, particularly those sort of on the mixed type IBS spectrum, will have urgency and even sometimes diarrhea or incontinence if we too aggressively start with Miralax. So
Sure.
that's something I've seen.
And with those mixed people, I'm usually more aggressive in treating the constipation than the diarrhea, because I always think of the mixed as like they get constipated, they get a little impacted, pressure built up, and then they have diarrhea afterwards. That's the way I think about it.
Yeah.
And I'll tell people, if I'm not sure, I'll tell them to take it at night, because usually it will not wake them up.
Right.
You know, like you said, the nocturnal stool is something that doesn't really fit with IBS, so it's not usually waking them up. So I'll usually have them take it at night, and that kind of helps.
So a lot of our patients come to us and they've done all this, right? Their thoughtful primary care physician has done fiber and has tried Miralax,
Sure.
and maybe even something else. So we get these patients that have become refractory to over-the-counter or first-line treatment. So what can we offer sort of beyond that, for starting with irritable bowel with constipation first? What's your go-to there?
For me, I mean, there's a lot of choices, and I don't know if there's any right answer, but a lot of times with any kind of prescription, you have to kind of start with, what you know is going to be covered by the insurance, or what you think might be covered.
That's a sad but true.
Sad but true.
Mm-hmm.
Sad but true. But I mean, I think a lot of us would like the Linzess or the Trulance. I like to start with those because I consider those relatively mild and well tolerated and pretty effective.
Okay.
I'll start with that.
Yeah, I do too, generally, and safe, and so I agree. Other options in this camp would be Amitiza, and I use the brand names because that's how we mostly talk about them, and I'm not going to bore you with a bunch of generic names that I can't even remember.
Right.
Lubiprostone, that's harder than Amitiza. And so Amitiza is an option. It has other indications, but the lower doses for IBS with constipation. And remember Zelnorm.
Oh yeah.
I like Zelnorm. You can still get it.
I don't use it a lot anymore.
And the problem is what you said earlier is availability and access for patients. It's expensive.
Yeah.
And we can still get it. And I have a lot of patients from a decade or more ago that did really well on that medication, and I call them Zelnorm casualties because they came off of it and they were much worse, and I had to try to find something to kind of patch them back up in the post-Zelnorm era. But now it's coming back on kind of a limited basis because it's hard to get because of cost, but don't forget Zelnorm in perhaps refractory patients. Okay.
And me too. I mean, I thought Zelnorm when it was out there was really good. It's just harder to use now because it's restricted.
And there also, I think, there's a real art to medical management of these patients. And part of the art is sometimes using medications creatively to help with symptoms. Really, we're trying to counteract a symptom that is really dragging a patient down. And so I think we've all used other things that are creative, maybe off-label. We're learning a lot about off-label medication use in the COVID-19 world, right? With using hydroxychloroquine, Plaquenil, or azithromycin. And so we sometimes use off-label medications in GI. It's something we need to talk about with our patients, but I think other medicines are used as well. We won't go into details on that, but sometimes we do have to get creative and reach into our back pocket and pull out some other medications. So that's a good overview of IBS-C. What about your IBS-D patients? Diarrhea predominant, different set of symptoms, opposite symptoms. You always try to not swing the pendulum from constipation to diarrhea, diarrhea to constipation. There's a real sort of like a fine line there sometimes in some patients. They have a trigger bowel, it can go either direction. But how about IBS-D? Give me a sort of an algorithm for that.
Okay, so for IBS-D, very, very common as well. And, I don't know if constipation or diarrhea is more alarming, but diarrhea, IBS-D is pretty common. And I usually start, if it's mild and there's abdominal pain associated with cramping, it's very common that people with IBS-D will have a lot of cramping. They hear their bowels moving around a lot. So then I'll tend to start, if it's the diarrhea part's mild, I'll start with something like Bentyl or Levsin, which is an anti-spasmodic.
Yep.
And I would start with those things. And those can sometimes help the diarrhea part of it. Because they're anticholinergics and they do slow down the GI tract. And I'll use them interchangeably. I mean, Bentyl or Levsin, I'm not sure which one I would use first,
Right.
but I do tend to use a lower dose of Bentyl than normally prescribed. I'll use a 10 milligram dose instead of 20, but
Right.
we can go up to 20. And then for the people that have more severe, and this is a little different for me, I think, than a lot of my colleagues, but I'll use Lomotil, which is a prescription, as opposed to something over the counter like Imodium, and I'll use a small amount of it. And I've had pretty good success with it. I haven't had people, there are people that overdo it, but for the most part they don't. And it can be pretty effective. And Lomotil is just a very strong anti-diarrheal medication. I just use it in limited amounts.
Okay, got you. Yeah, so you mentioned over the counter. Anti-diarrheals. Again, a lot of times we're seeing patients sort of after they've forayed into over-the-counter treatments like Imodium you mentioned, and like Kaopectate, Pepto-Bismol, probiotics, often used by patients now, right?
Absolutely.
Don't you see that? And what about a couple of things I wanted to ask you about, other sort of prescription options for these patients, and then diet options for these patients. Talk to me about what sort of prescriptions we can utilize for these patients, the Ds. What do you tend to use there?
Well, one of the old drugs that we used to use is Lotronex, which I thought was fantastic.
I love Lotronex.
Yeah.
I still use it.
Do you? I use it a little bit.
I use it. It's got a history of being pulled from the market and then relaunched, having sort of some special sort of parameters under which you could use it. But it's a really good drug affecting serotonin, right? It's a serotonin blocker. So what else? Do you use much Viberzi? No? Yeah.
There's too many things that we deal with. For me.
Yeah.
And, I think you have to be pretty compulsive because there's
Sure.
too many things that we deal with in GI that, my patients have that make me concerning, that you have to ask. And you can spend the time and ask, but I'll use Lomotil instead of Viberzi.
Yeah.
I would tend to do that.
Okay, I got you. So, what about antibiotic therapy for these patients? Xifaxan.
Yes.
Yay or nay on Xifaxan?
I'm still deciding. I've had some success, but it's expensive, hard to cover, but it is covered for this, and I have been able to get patients for this, and I've had some success with it. I'm sorry.
Yeah, I got you. And I love the drug. So it's a very poorly absorbed antibiotic that sort of rebalances the bacteria in the gut. So it's not really absorbed into the body. It just works in the gut, and it can treat bacterial overgrowth that we talked about at the intro. And if there is a gut bacterial imbalance or frank bacterial overgrowth, it may actually resolve symptoms. Now that can recur, but it's really the only drug I've found in our arsenal of drugs for this condition where you can really almost cure patients. Sometimes temporarily, you can retreat, but it has potential to really abolish symptoms. And I've had some patients who were really, really pleased with Xifaxan. Again, that's not most patients, but you do have that potential with Xifaxan. But if you're listening, insurance companies, if you're listening, Medicare, if you're listening, drug company that makes Xifaxan, I can't remember who they are off the top of my head, then we need to be able to get that medicine funded better than it is because it's really a problem. So I'll stop there.
I'll agree with you on that.
Yeah.
I mean, I would like to use it more. If I had it more available, I think I would use more of it. And like I said, I've had good success with it.
Yeah,
So.
absolutely. Thank you guys as always, and we wish you good health as you navigate these sort of tough waters in this COVID-19 pandemic. So be safe, be careful out there, and from the shadow of Vulcan, right back this way, stay regular.